So when we take a patient, send a patient to electrophysiology lab for an ablation, usually we're doing that for tachydysrhythmias. So patients that have supraventricular tachycardia, atrial fib, atrial flutter, syncope, it's being caused by syncope, some cells or something. We can do a lot of stuff. We can find the heart cells, we can electrically stimulate the ones, find the ones that are causing the problems, and then we can kill those cells. Sometimes if things go wrong in the EP lab, we may have to cardioverter defibrillate the patient. Patient is usually under conscious sedation for this. They put a lot of lines. They use the central venous lines in the subclavian or lines in the neck. This can take hours. I've seen patients go to EP lab and they're on that heart table anywhere from 3 to 6, 7 hours. It takes a long time to map out all the cells in your ventricle or atria and then find the cell that's causing the problem. What's sad about this is I've seen patients take hours in the lab. They come back and they say, well, we found the cells that are causing atrial fib, and the next day they go back into AFib. There you go. They wouldn't take someone to EP lab until they've tried other means. So they've tried medication, they tried to cardiovert them, they've done everything that's less invasive first. This would be your last resort to try to fix that dysrhythmia. So if nothing else works and the patient still has symptoms, then we'll take them to EP lab. So after EP lab, patient comes back and they may have lots of different catheters, very large catheters like giant IVs in all of the subclavian and in your neck vein. So there also may be an arterial catheter in the arm. So it takes quite a while to recover these patients, to get the heparin normalized out of the blood, and then to pull all those different catheters. So premature ventricular contraction. A lot of patients have these. The older you get, it's normal for a patient to have PVCs. So check the patient. They may not even know they're having them. And if they have a lot, then they would have symptoms. So here's 3 medications that you could give the patient: amiodarone, pronestil, lidocaine. So if a patient has a lot of PVCs, we usually put them on medicine, and that will control the PVCs. Patient won't have any symptoms, and they live just fine with it. Supraventricular tachycardia. We don't know where that's coming from, but if it's going really fast, then we need to do something about it. So we need to check the patient. Usually to break the cycle for supraventricular tachycardia, and sometimes for a patient that goes into a flutter as well, we basically try to do a Valsalva maneuver. So have the patient bear down instead of having a BM, cough really hard. You try to break that circuit of tachycardia, and sometimes those means will break the circuit and they'll go back into a normal sinus rhythm. If it doesn't, we try medication. So here's some medication that will help the patient. So we have a beta blocker, a calcium channel blocker. These will slow down the electrical pathway and hopefully stop the tachycardia. Send them to EP lab if that's what we need to do. It looks on a EKG of someone, sometimes the supraventricular rhythm on an EKG looks like VTAC, but you have to be very careful and make sure you get a 12 lead for the VTAC for SVT, because if it's not VTAC and you shock them with defibrillation paddles, it can cause them to go into a lethal rhythm. So you have to be very careful when taking care of SVT. There's a medication called adenosine. It's over here, right here, adenosine. Adenosine basically stops the heart very quickly and then resets it and when it comes back to beating, you hope it's in a sinus rhythm. Here's an EKG where they had a patient. Notice over here on this 12 lead, this is a 12 lead. Here's leads 1, 2, 3, V1, and so we're basically giving them the rhythm. Here's their SVT. We give the cardioversion, or I'm sorry, the adenosine. You give it really fast to an IV. It instantly stops the heart. Here it is. Stops the heart. Now we have a PVC, it looks like. And now we go into a sinus rhythm. So there we have a sinus rhythm. So stop the heart, wait for it to restart. Here we go right here. Normal sinus rhythm. Kind of cool. Okay, second degree heart block. Type 1, if the patient is too low and they're having symptoms, we can put in a temporary pacer. We can give them that atropine. Type 2 heart block. Notice I don't have type 1 heart block up here, first degree, because people live with that and you're fine. Type 2 second degree heart block, or Mobitz type 2, type 1 second degree heart block. It's called Mobitz 1 or Winky-Bach. This can progress to third degree heart block. So if you keep dropping more and more P waves, you may have to get a permanent pacemaker. So it depends on symptoms, but yeah, you probably need a pacemaker if it's a lot of drop beats in type 2. Definitely if it goes to type 3, you will get a pacemaker. It's more common with patients that had rheumatic heart disease. Third degree heart block, if you're not close to getting medical services and it goes into third degree and your heart just beats at 20 beats a minute because the ventricle is now initiating your heartbeat, it could be lethal. It's life-threatening. You could die if you don't get it fixed. These patients need an internal pacemaker. Ventricular fibrillation. Check the patient, check the leads. Most patients that go into this pass out. So CPR and defibrillation. Basically follow ACLS, advanced cardiac life support monitor. If you are certified as an ACLS nurse, then you know what needs to be done. These patients basically, if it happens more than once, they should probably have a automated implantable cardioverter defibrillator, AICD, implanted. Here's a patient with a AICD. Obviously, it's starting to come out. Not a good thing. So they'll have to reinsert that. The AICDs and pacemakers are getting smaller and smaller. Wasn't that many years ago, 15 years ago, they were still pretty big. So that's where they are implanted. So care of a patient with an AICD or someone that gets a pacemaker, they're going to have a dressing in place, going to have sutures, they're going to suture that in. They may ooze from the side, they may get an infection in the side. They need to keep that left arm down below the shoulder for about a month. Sutures usually are dissolvable sutures, so they will just dissolve, don't have to take them out. If a patient is shocked with the AICD, they need to contact the office, physician's office that has shocked them. They'll know when it's shocked. Patients say it feels like being kicked in the chest by a horse, so they'll know it. They need to carry an ID card at all times to tell them the information about their implantable AICD. When they go through the airport security, they need to show that card and say, hey, I've got an AICD, don't use one of those wands on me, the magic wand. Same kind of things for recovery would be the same for a pacemaker. So if a patient is monitored and goes into asystole, you need to check the wires, obviously, because they might have just come off. So don't go in and want to shock the patient if they're sitting up in bed. If they are in asystole, start CPR, the ACLS protocol. So as the nurse, you would just hit the code button and start CPR. You would do that on any patient that stopped breathing or also instantly passed out. VTAC, the patient goes into VTAC. We need to check the patient and the leads. Is it true VTAC? Is there a pulse? If there is a pulse, because some patients have a pulse with VTAC. VTAC can be pulseless or it could be without a pulse. I'm sorry, pulseless or with a pulse. So obviously if they have a pulse, they might be awake. So need to check that out. So if they have a pulse, let's do cardioversion at 100 joules. Let's start off very slow, low amount of electrical power and see if we can convert them into a normal rhythm. If no pulse, then we're going to CPR them and defibrillate them. So follow the ACLS protocol. These patients, if it happens more than once, then perhaps they need an AICD as well. So pacemakers, implantable pacemakers, they are either atrial or ventricular paced. You would see pacer spikes on the EKG if they have these, so you can be dual paced or single paced. Recovery is the same with AICD. They can set the rate for when the pacer will kick in. If the heart rate drops at this level, it kicks in. So they can set it so it'll work really efficiently for the patient. So they can set the pacemaker. Patient has to be checked up on, see the doctor. They run electrical analysis of your pacemaker, see how many times it's charging, not charging, how many times it's sending an impulse, is it working correctly, things of that nature. So pacemakers like AICDs might have bleeding, watch for an infection. They have to keep that arm down for a month. Sutures dissolve. They can't put large magnets over the pacemaker. Otherwise, that'll stop the pacemaker from working. Microwaves will not deactivate a pacemaker. Batteries will need to be replaced 5-10 years, depending how often it is pacing you. You need to carry that ID card. Patients can't drive for a week afterwards. They can't lift anything with that left arm. They shouldn't lift anything with either arm. More than 10 pounds, shouldn't push, pull, can't mow the lawn. Lots of things you should not do while that month of healing is taking place. Once again, there's an example of ventricular pacing right there, ventricular pacing. Notice a very wide QRS after each ventricular spike. Another picture of your atrial and ventricular spikes. This is dual paced. So, myocardial infarction. If a patient has an MI and they're actively having an MI, we know what's going on. We can put them on an EKG. Here's what your normal EKG should be. Notice this line right here. This is called the isoelectric line. Well, if we measure, remember we had a PR interval, we have a QRST interval, we do all this stuff. There's one here called the ST interval. At the end of the QRS, right here at the S, and the start of the T is this interval. That interval pretty much should always be isoelectric down. If a patient is having a heart attack, that ST segment will elevate. Notice it raises that Q, that S and the T area, raises it right up off the isoelectric line. This is a sign that a patient is not getting oxygen to one or more of their coronary arteries. This is called ST elevation. Sign of a heart attack, no oxygen. Here is a horrible one right here, ST elevation, huge. This is what they sometimes call in critical care tombstones. I mean, if we don't do something quick, that patient's going to lose a lot of heart muscle. Heart muscle in a heart attack without oxygen and getting blood flow to the heart means you are going to have damage. Here is a really bad example of ST elevation on a 12 lead. Huge over here. I mean, those aren't just tombstones, they're double tomb. Those are mausoleum stones, they're not tombstones. Here's some more elevated ones. MI on a EKG monitor. You can even see it on the monitor here. This is an example of a patient that had an MI. They went to the cath lab. They did a procedure. And over just a very short amount of time, opening up that coronary artery, we went from tombstones, and then it finally gets to be a normal ST segment that's not elevated. So lots of arrhythmias, dysrhythmias, they're going to look at the patient's age, their comorbidities, their symptoms. Treatment should only be given if it's going to benefit the patient. If the benefit outweighs the risk, then it'll be done. There are some patients that probably need to go to cath lab, and they will die from a heart attack, but because of lots of issues, that's too risky to take them to cath lab. It's too risky to have open heart surgery, bypass surgery. So treatments of any heart condition, benefits should outweigh the risk for the patient. So, things you should remember for the upcoming test. Make sure you understand the different dysrhythmias. What does pacer spikes look like? Third degree heart block. How does this affect heart function? Medication use. Here's some definitions. What does it mean? How would you teach these patients? How would you monitor? What does it mean when someone's having AFib, a flutter? What are the complications?